Welcome everyone to CCHP's Medicaid and State Telehealth Policy Summer Series webinar. This is our third webinar in 4 webinar series. Today's topic will be telehealth private payer laws. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy. A few housekeeping items before we get started. Please note that any information provided in today's webinar is not to be considered legal advice. It is strictly for informational and educational purposes. CCHP always recommends that you consult with legal counsel if you are interested in a formal legal opinion. Also know that if a product or company name is mentioned, know that CCHP has no relevant financial interest, arrangement, or affiliation with any organizations related to such products. Today's webinar is being recorded and the slides and the recording will be made available in a few days after the webinar on CCHP's website at cchpca.org. Closed captioning is also available, so you'll find that button on your toolbar in Zoom, and you can just click that if you wish to activate the closed captioning. We also ask that all of our attendees please refrain from any political statements or advertising commercial products or services during this webinar. Additionally, if you have questions for our panelists, we ask that you put it in the Q&A function. The chat function should be strictly only used for technical questions regarding Zoom, or if you have questions regarding the recording or the availability of the slides. Also know that today's webinar is being funded by and is being sponsored by CCHP's non-federal funding. A bit of background about CCHP. We were established in 2009 as a program underneath the Public Health Institute as a California telehealth policy organization. We became the federally designated National Telehealth Policy Resource Center when a grant became available in 2012 through HRSA. CCHP applied for it, we got it, and we've been serving in that capacity ever since. We also work with a variety of other funders and partners on the state and federal levels on different projects. We act as an administrator for the National Consortium of Telehealth Resource Centers, and we are the convener for the California Telehealth Policy Coalition. National Consortium of Telehealth Resource Centers are made up of the 14 telehealth resource centers who receive funding from HRSA underneath the same program as CCHP. There are 2 national centers, one on policy, which is CCHP, and one on technology that's based out of Alaska. And then there are 12 regional resource centers that cover specific states. They field all questions regarding telehealth from program operations to policy and technology. So I highly encourage you to reach out to your regional telehealth resource center if you have any questions regarding telehealth. All 14 telehealth resource centers do work closely and collaboratively together underneath the umbrella of the National Consortium of TRCs. So you can actually reach out to any of us. You're sort of really receiving help from all 14, but I highly encourage you, if you are in a specific state, to reach out to the regional telehealth resource center that covers that state. This is, as I said, the third of a 4-part webinar series that's taking place this summer. The 4th one will be on June 24th on substance use disorder. 2 previous webinars, one on school-based and telehealth and on licensure, took place the 2 previous weeks, and those recordings are available on CCHP's website. This particular webinar, though, is being sponsored by CCHP through non-federal funding, so it is not underneath our HRSA grant that this webinar is taking place. It is taking place under other funding that CCHP has. We are very fortunate to be joined by a great panelist of speaker. We'll hear first from Representative David Bentz, who's with the Delaware House of Representatives. We'll then hear from Mike Rhodes, who's with the Oklahoma Department of Insurance, and then Kevin Began, who is with the Massachusetts Division of Insurance, and lastly from Chelsea Matter, who is with Blue Cross Blue Shield of North Dakota. We'll first start off with Representative David Bentz, who serves as a Delaware State Representative and Chair of the House Health and Human Development Committee. He also works as an adjunct professor of public policy at the University of Delaware. Before holding elected office, he earned a bachelor's degree in political science from Penn State University, a master's of public administration from the University of Delaware, and served as a legislative aide in the Delaware House of Representatives. So I will now turn it over to Representative Bentz.
Thank you. Thanks for the introduction, and thanks for the invitation to participate in this today. Looking forward to sharing some thoughts and some I guess, some information about how Delaware developed its telehealth policy. It's been something I've been working on for quite some time as chair of the Health and Human Development Committee here. So just as we get started here, I just want to, again, thank everybody for the opportunity, and good morning, good afternoon, wherever you may be. It's afternoon where I am. Going on, just a quick overview of kind of the timeline of how we got where we are. It's, telehealth has been around for a while, longer than obviously the time frame in which government decided it needed to kind of get involved and make sure this was being done in a safe and sort of effective way. And before government sort of was being asked to step in a way that was going to ensure that it was working properly. So in Delaware, this effort kind of started in the early 2010s. You're going to see as we move through some of these slides a little bit more, there's just kind of distinct phases of policy development here. Really through two distinct phases. There was that sort of initial phase where we were hearing from providers and patients and payers about the need for some sort of statutory and regulatory framework to allow this to work, allow people to have access to it, for providers to be able to provide it, and obviously be compensated for providing it. So there was some, that demand, that initial request for the government to step in and provide some sort of rules and regulations around how this was going to work. And then kind of a relatively quiet period where, there wasn't a whole lot going on, where this was still, the uptake was still going on, and government had sort of passed its policies and its regulations, and it was sort of working on its own. And then, of course, like the rest of the world, they all kind of got turned on its head through the COVID-19 pandemic. And we saw what happens when just such a large quantity of healthcare delivery had to happen through telehealth. And that created new demands on the system, and a real learning experience in a lot of ways about the possibilities and the opportunities provided by telehealth, and really what maybe government could do through the pandemic, but then what this all could look like in a post-pandemic world, which hopefully we get to at some point. And I'll talk a little bit more in detail about these two phases as we move forward. So a little bit about sort of this initial use, and to be fair, I was first elected in 2015. So you're going to see we actually didn't pass any bills on telehealth till 2015. So a lot of this sort of initial work took place when either I was a student or when I was a legislative staffer. I did have the benefit of, when I was a legislative staffer, I staffed the Health and Human Development Committee chair. So I was familiar with sort of the ongoing work about what was needed, and was part of those conversations from a staffer, but I didn't sponsor any of this legislation. But what we kind of were seeing in that early part of the 2010s was that this was being used, right? The technology had been in place and had been in use for some time. Providers were delivering telehealth. Patients were utilizing it, but it was obviously something that was not particularly well regulated, or there wasn't much in insurance regulation or even public health regulation about how this was going to work. But the technology had been in place, and we started to hear from patients, from payers, and from providers that this is something that's on the frontier of healthcare, and government is obviously typically a lagging indicator of this. We tend to sort of come along after the fact, after something's being done, and try to catch up and make sure it's operating appropriately. So when we started to hear from providers and patients that they wanted to use this, and some sort of need for a regulatory or statutory framework was going to be required, was when we started to have some development. Now, government obviously moves slow, like I said, slow on the uptake, and slow to sort of build consensus around what this framework is going to look like. But we kind of entered into this policy development stage where a number of working groups were brought together to sort of figure out what we were going to do with this. The first one was the Delaware Telehealth Coalition. This was actually a group of non-governmental entities who were working in this space and wanted to sort of get the ball rolling on this. And they began discussing, what types of public policy interventions were going to be needed to make sure we set up an environment where telehealth could continue to expand and thrive, but then also be safe and effective for everybody. And then we, after about, that formed in 2011. And then in 2013 was when, 2012 actually was the first, when Medicaid began reimbursing where Delaware Medicaid began reimbursing for telehealth. So that was a big step as well. And that was sort of the impetus for government to get involved in 2012, 2013, which kind of reimagined this Delaware Telehealth Coalition with government involvement, with our Department of Health and Social Services, our Department of Insurance, and various entities getting involved as well. And we created a 3-year strategic action plan, which was going to work us through developing statutory and regulatory framework like we discussed. The first legislation that we passed, like it says here, was House Bill 69, and that was passed in May of 2015. So all in all, this process took about 4 years from when we started to get advocacy to when a bill was passed. But this is when you're working on kind of what's a frontier of healthcare, an already complicated subject matter with a lot of moving parts, a lot of involved parties, it sometimes just takes a lot of work. But I would say that the big early stage steps that Delaware took to sort of promote this and make sure it was going to be available was, that first step of reimbursing through Medicaid, and then the passage of House Bill 69, which encouraged insurers and providers to use this by making sure that they were going to be compensated for it. So then, we had this relative quiet period from 2015 to 2020 around telehealth. There wasn't really any amendments being made to the existing statute. The regulations were working and doing what they were supposed to do. I'll tell you, it was limited in its use and limited in how and where it could be used. And so there were some pretty tight parameters on, how telehealth was going to be allowed in Delaware. So I think we probably weren't at the forefront in allowing this to happen in as many places as probably some other jurisdictions, but we did have it, and it seemed to be working for our state at that particular time. And then, of course, the COVID-19 pandemic occurred, and utilization spiked dramatically. And yeah, the answer I see to this question is this only for Delaware? Yes, I'm only talking about Delaware specific policy development. I don't think we're outside the box of how other states have addressed this, but for this purpose of this presentation, yeah, I'm speaking about Delaware's path here. But we saw a dramatic increase in utilization around the COVID-19 pandemic, about 100 times the amount of claims in the spring of 2020, in the months around the spring of 2020 than what we typically saw. So we went from a couple hundred claims a month. Delaware has an all claims database, so using that data, we looked at it. What were telehealth related insurance claims the year preceding the pandemic? It was a couple hundred a month. We're a small state, but then it jumped to over 40,000 claims per month for April and May of 2020. So we actually saw this, great increase in utilization, and around that there was obviously a real need for that because people couldn't safely go visit their doctor in person, and physicians' offices were really just seeing people who absolutely had to be seen in person. But with healthcare delivery, kind of needed to move to the virtual setting. To sort of facilitate the ability to continue to do that through emergency orders and public health emergency orders, the governor suspended basically all of our regulations around telehealth and the limitations that were put on it. That happened in March of 2020. This allowed for things like out-of-state providers to offer telehealth services into the state. All they really had to do at that point, they didn't have to be Delaware license holders. They just sort of had to deliver a piece of paper to our Department of Professional Regulation that kind of said, hey, I'm here, I'm delivering telehealth services into Delaware. Suspension of the requirements for established relationships to be patient-provider relationships to be established by in person before telehealth could be delivered. We got rid of that. There were prescribing limitations that were placed, especially around controlled substances and whether these could be prescribed by telehealth. We suspended those as well. And those emergency order provisions were in place for a few months. And then in the summer of 2020, as the governor sort of came to the legislature and said, hey, I'd like to roll back some of these emergency provisions and not just have them be executive orders, we passed a piece of legislation that codified a lot of those emergency order provisions, with the exception being the out-of-state non-Delaware license holders being able to provide telehealth into state. That was sort of a disagreement that existed amongst some people, so we kind of left that out. And that piece of legislation was only in place for a year. We put an expiration date on that bill because we wanted it really to just be able to get rid of the emergency order and then buy us some time to figure out what we wanted to do in the long term. And you're going to see this as I talk a little bit later on the next slide about sort of what the learning experience of COVID-19 was like and how it informed some more longer term decision making we've made in this state about how telehealth is going to work. So in about a year ago, it was around June of 2021, we passed in Delaware what we called the Telehealth Modernization Act. With the rapid increase in utilization that has slowed down around COVID-19, but it hasn't, we're not back to where we were, to the low levels we were before. It's still much, much higher. That allowed us to learn a lot about what works with telehealth, what opportunities it provides us, what limitations it has. And it gave us sort of a forced opportunity to just have a real consume drink by a fire hose opportunity of information and data to come in so we could figure out what's working here, what isn't, and if we wanted to make changes to our existing statute, what could we put in place for the long term. And what we learned was that there was a lot of comfort with telehealth, both from the provider and the patients. This was one thing maybe that was a forced comfort because they had to get this, that they had no other choice, the providers and the patients, but what we were hearing was just, this is working for people. And that there are certain sorts of consultations and checkups and wellness checks that really probably don't require everything going back into in-person settings, even in a post-pandemic world. And what that led us to do was to look about how we were going to be able to do that safely and make sure standards of care were met with sort of a laxed regulatory structure. We also in Delaware have some specific challenges around what I like to call small state problems. We have a population that is almost the entire state is within a half an hour of the border of another state. So we have citizens here who their doctor's in another state, right? So if you're living right there on the border of Pennsylvania or of New Jersey or Maryland, your primary care doc may just be in another state. That may just be the way it is. You may utilize, when you're sick and you need a hospital, you may go to Hopkins in Baltimore. You may go into a hospital in Philadelphia to get care. This may just be the convenient way for you to go about that. So, and if we have sort of specialist shortages, if we have behavioral health shortages, we can sort of fill in some gaps that we have by allowing telehealth into other states. So what we saw was a lot of challenges around licensure and how do you accommodate residents of our state who utilize healthcare services from outside the state, and how do we give them the same opportunity to access telehealth as everybody else would if it's in state. So one of the things we did was enter into a lot of interstate licensing compacts, which opens the door for telehealth delivery into the state. We expanded greatly for behavioral health telehealth opportunities, which was, we're like a lot of places, we have an incredible shortage of behavioral health experts and providers in our state, and people need to be able to continue to access that in other states. It's just sort of the reality of our situation here. And we're talking now a lot about just licensure reciprocity. So these interstate compacts are fantastic, but what happens if the state you want to work with is, for example, not in one of those compacts? And then you need to work almost with that state instead of working with a centralized entity that regulates and does the operations of these compacts. You need to work directly with that specific state and their professional licensing boards to develop some amount of reciprocity. And we've done that with, the big state in our area of the country is Pennsylvania, where Delaware needs to have access to that. And obviously, we continue to pursue payment parity efforts. There's been a lot of work around that. It's still not quite on par with where we need it to be. And we still hear about instances where insurance plans aren't paying the same levels, and they're not paying for, all sort of their various forms of telehealth delivery, whether that be, say, maybe audio only telehealth, which is something we've allowed in the state since the COVID-19 pandemic that we haven't rolled back either. So we continue to sort of work around that. Some of this has been put into statute through, like I said, a piece of legislation that modernized a lot of this. A lot of what we were hearing was we kind of let the cat out of the bag with a lot of the stuff, and people were enjoying it. So to go back to sort of a pre-COVID-19 scenario with those restrictions was not something that was going to be feasible for people or seen as appropriate. So, we've really been able to expand usage through our statutory and regulatory processes here. And it's I think what I'm hearing from constituents, what I'm hearing from industry is that this works. And it's what we've learned from COVID-19 really is that this is going to continue to be utilized more and more, even in a world where COVID-19 is not doing the kind of wreaking the havoc that it has been. So that's it for my presentation. Again, if you have any questions for me and you want to reach out to me after this, there's some information about how you can reach out to me to learn a little bit more about our personal experience here in Delaware. You said this is a continuing to evolve policy area, and I don't expect that to change. Like you said, it's been 10 years of pretty consistent action in our state about constantly updating this and making sure it's meeting the needs of everybody involved in the healthcare industry, and it's not going to change. So, if you have any more specific questions for me, I'd love to answer them, and you can reach out to me there on the email address provided. But thanks everybody for your time.
Thank you, Representative Bentz. That was a great presentation and great overview of what happened in Delaware. We'll take one or two questions from the audience for you, but I had a question for you. And I'm not sure how much you can go into it because, as you mentioned, it was a little bit before your time. But the group that worked on the 2015 bill, you had said that there were actually various state agencies that were involved in that sort of collaborative coalition or that process there. Was that instigated by like a legislative bill directing that, or a direction from the governor? I mean, how actually did that get started with like that input from like state agencies to like work on that?
Sure. So it actually started with there was a non-governmental entity that formed kind of on their own volition that was going to try to outline the need to the government. It was just what they were kind of going to need from regulators and from legislators. And then they were able to kind of pull in the government entities that were existing through the executive branch. So it was, at some point there was a realization from the governor's office and the administration that we're going to need to do something like this. Here's the group. Let's involve our Department of Health into those conversations, our Department of Insurance into those conversations, and we can form one entity that's both non-governmental and governmental, get everybody into the same working group and start figuring out how this was going to have to work.
That's really interesting because we've noticed, like, at least in a couple of other states, it's been more of a grassroots process where it has been like those non-government entities that maybe have taken it to like a specific legislator to get something started. But Delaware is an interesting example where you actually have that government input from the beginning and helping to craft it.
Yeah.
So we'll take a question from the audience here. We have one from Ashiva Jones. For Representative Bentz, did you see an overall uptake in total claims as a whole with availability of telehealth, or did you see the same claims with more coming through telehealth? I actually don't know if you'll be able to answer that. That's like kind of in the weeds on the data there.
Yeah, so what we've seen, I can talk generally about how claims, the trending in claims has happened. Now, we didn't have an all claims sort of tracking database until I think about 3-4 years ago. So we don't necessarily have all that data in a government vault, so to speak. Well, it's been consistent uptake, and that's pre-COVID. It was a consistent uptake. But what we saw obviously was like I said, it went from several hundred claims a month to 40,000 claims a month during the height of the pandemic. Now that's come down, but it's not come down the whole way back to a couple hundred. It's still in the thousands of claims. And what we've seen is that there hasn't been a complete reversal back to a pre-pandemic level of usage and utilization on telehealth. This is something that, is going to continue to trend up as providers are comfortable with it, as technology spreads, as other limitations and things go away. We're seeing investment in broadband in rural areas, for instance, and that's a hindrance to people using telehealth. And as that sort of technology expands, there's going to be more demand developed out of that. So this is we've seen the trends continue to go up from, they're not go all the way back down to pre-COVID levels, and I don't anticipate ever being back there. It's just always going to be something I think that's trending up in utilization, and not something that's going to decrease.
We'll take one last question from the audience, and Representative Bentz will be back towards the end of the webinar. From Sarah Hines, and I apologize ahead of time if I pronounce anybody's name wrong. What were some of the arguments against allowing out-of-state providers to deliver services via telehealth in Delaware on a permanent basis? Like, this goes to your small state syndrome that you were talking about.
Yeah, it's a real challenge, and it's the pushback was from the licensing people, the licensing boards. I think there was some concern about, I think there's inevitable concern about competition, but I also think generally where the concern came from was from regulators who were legitimately concerned about the safety, concerned about what actors are we allowing to come operate in our state if there's no licensing guidelines, if there's no, and licensing guidelines and requirements vary from state to state quite a bit. Some are very strict and have higher standards, and others have much lower ones. So I think that there was general concern about who are we letting operate in our state, and is that putting Delawareans at risk? And that was an area of disagreement amongst, even within government. I think the legislature was much more comfortable sort of blowing the doors off this, and then in the executive branch, we saw a little bit more like trying to corral us a little bit, and bringing up what they saw as potential sort of gaps in safety, and that's their job, right? They're supposed to regulate the industry and make sure it's operating safely. So that was what we heard from them, and that they wanted some ability to be able to take disciplinary action if somebody was a bad actor. And without having any sort of licensing requirements on them, there's no recourse you have. If they're just allowed to operate without holding a license, then there's nothing to take away from them to stop them from practicing if they end up being a bad actor. So that was kind of the divide and the arguments against making that provision permanent.
All right. Thank you. I'm sorry we couldn't get to all the questions, but as I said, Representative Bentz will be back towards the end of our webinar when we bring back all our panelists. Thank you, Representative Bentz. Yeah. Next, we will move on to Mike Rhodes, who's Deputy Commissioner with the Oklahoma Insurance Commission. But before we do that, and as I pull up his slides, there have been several questions asking about, are these very state-specific presentations? And yes, for now it is. The reason we set it up this way was to provide people with how private payer laws have evolved, and also what happens to them after the legislation has been put in place. And that's what we're going to hear from our next couple of speakers. We're going to hear from two different insurance commissions and like how they actually enforce these private payer laws. And then we will hear from a payer on like what has been the impact on a payer or a commercial payer who is really subject to these laws. So again, we want to thank Representative Bentz for telling us like how a law gets into place, how it evolved that way. That was one example. But now we are going to hear from the enforcers on like what happens after the law is actually in place here. And again, I want to introduce Mike Rhodes, who is an insurance and banking executive with 40 years of combined experience in these industries. He retired from Blue Cross Blue Shield of Oklahoma in 2008, where he served in various capacities during his 25 career with the health insurance company. Mr. Rhodes was most recently the president and senior consultant of the Rhodes Advisory Group, a consulting firm working with the insurance industry in Oklahoma and Texas. He has served as Deputy Commissioner of Health and Life Insurance at the Oklahoma Department of Insurance since 2011. And I will now turn it over to Deputy Commissioner Rhodes.
Well, thank you very much. I really like that term enforcer, because that certainly is what the regulator is required to do, enforce the statutes. I will make a preliminary comment that I think that Oklahoma's regulatory experience with telemedicine is quite a bit different than what we just heard from Delaware. And that's not unusual. I think that every state has got different elements with respect to how they need to serve their population. So the first mention of telemedicine as a program was really a clinical tool that occurred almost 30 years ago when the University of Oklahoma established a telecommunications network with these 45 rural, 15 regional hospitals through the OU Health Services Center. It really was, as I mentioned, a clinical tool developed for speaking to the needs, particularly in rural Oklahoma, but also in the urban areas. And there was a reimbursement mechanism established back in those days. And it was really the first generation of store and forward telemedicine. I don't know what that reimbursement was, but we probably would also recognize that telemedicine was just perhaps coming into health benefit plans as a benefit back some 30 years ago, back in 1993. But 4 years later, the Oklahoma legislature passed the Oklahoma Telemedicine Act. There's the statutory citation in the slide. It was a mandate for reimbursement for all healthcare benefit plans, including disability plans, workers' comp, and the Medicaid managed care program that was then, at that point in time, operating in Oklahoma. A few years later, in 2011, passage of a legislative measure, the Oklahoma Special Universal Services Fund. And this really was to begin to build out that infrastructure here in Oklahoma. And it was a no-charge broadband network to eligible healthcare entities. These were really the entities that were in need of some particular help with respect to servicing their patients, not-for-profit hospitals, rural not-for-profit hospitals, public health departments, correctional facilities, FQHCs, and these community mental health clinics that were beginning to populate here in Oklahoma. In 2016, the statute was amended to prohibit the exclusion of telemedicine, and it really began to expand the modalities with respect to what was going to be covered. There were, at this point in time, the identification of synchronous mechanisms, and that's what we know now today as audio-visual interaction between the patient and the provider. In addition, the asynchronous mechanism, which is store and forward and online exchange of health information. But at that point in time in 2016, we also added the remote patient monitoring component, and as well as some health-related education. What's not shown on the timeline here is the impact of the pandemic on telehealth here in Oklahoma. Use of the service, as David mentioned, escalated rapidly with the declaration of the public health emergency. And we also note the use of audio only being acceptable as a telemedicine process. And that was allowed by HHS, the Office of Civil Rights Guidance, and it was consistent with the HIPAA regulations. That was an executive order by the Biden administration. It was also during this period of time, during the pandemic, that we began to see the lobbying efforts for the reimbursement of parity of telemedicine visits by providers. And that occurred in 2021 when we again amended 6803 to include the reimbursement as well as benefit parity. That became effective at the beginning of this year. And this really was summarized quite well by the spring report by CCHP, where it said, added much more detail to their private payer law that made sure to include Medicaid as an insurer, and that the law is applicable to not only them, but also allows insurers to limit telehealth to coding and clinical standards set by the AMA or CMS. The new law also adds parity and prohibits insurers from limiting reimbursement to specific vendors. So the parity has now been put into place. We have seen, to a large extent, continuation of higher utilization, although that has trended down somewhat, certainly in the last half of 2021. And we'll talk about that a little bit more as we go through the presentation here. I wanted to mention on the next slide, the Project Echo. Oklahoma is one of the Project Echo hubs in the country. There's 175 of these. They operate in 46 states. And really, Project Echo is a telemedicine approach. It certainly has been beneficial to Oklahoma, sponsored by the Oklahoma State University Health Sciences Center. And these are virtual clinics to rural PCPs in the underserved populations in rural Oklahoma. Specialist teams not only treat chronic and complex medical conditions that are pervasive in certainly the Oklahoma population, but also these 5 special programs that are mentioned here, the mental health echo, which really is a addiction assistance to providers that are offering services to this population, psychiatric services, certainly on the education side, the education echo, it's a mental health component for schools. Veterans echo is very similar to that, population specific, both mental health as well as chronic diseases. We have here in Oklahoma, because we are a rural state, farmers and ranchers. We have a high incidence of suicide in this population. So there's a mental health component here for this ECHO program. And also most recently Heal the Healer, which was a program for the first line providers. Certainly during the pandemic, it's a mental health component also. And then let me go quickly into some of the trends that we're seeing here in Oklahoma. It's really, I guess, not a surprise, but we have high compliance to the statutory requirements under the 6803. We've had no reported compliance issues as reported through our consumer assistance area. Those numbers are flat. The passage of the Parity program in the 2021 legislative session allowed for inclusion of some of those rate changes in form filings in policy year 2022. I will note here that, and perhaps some other states have seen this also, we did have some consumer complaints on misleading ACA issuer marketing names displayed on the healthcare.gov. And this really impacted virtual care benefits. There was a lot of copay confusion out there. This typically was about a marketing name that indicated that telehealth was going to be, virtual telehealth sessions were going to be copay delivered without a copay. And that really was a misstatement. CMS has stepped in, certainly to the Oklahoma marketplace, and I think many other states, and has required some benefit description clarifications be put out on healthcare.gov. We had one very egregious carrier that really kind of blew the socks off of everyone. CMS has imposed a special enrollment period on this carrier, and their members are given the opportunity to go in and either select a different carrier or to understand in a more complete fashion what their telehealth and their virtual care benefits are. We have not seen through almost the first half of the year here any virtual first primary care product filings. We're keeping an eye on those. We did note a decline in telehealth visits in the last half of 2021. That's pretty much stabilized. And some of the reports that I have seen indicate that that's probably the case across the country. We have a continued infrastructure issue here in Oklahoma, and that is 1/3 of the rural counties have limited broadband. I've been told that this is not the American Rescue Plan Act funding, but the infrastructure funding, and that some distribution of those funds is currently being discussed in a special session of the legislature that is concurrent. Yesterday in the Wall Street Journal, if you are a reader of that newspaper, there was a highlighted community here in Oklahoma, Heavener, Oklahoma, that was reported as one of those typical examples of not having broadband coverage, not having sufficient speed for either download or upload. And it is continuing to be a problem here in Oklahoma. We think that it's going to be rectified. There are federal funds available for that, but you can't have telemedicine without the infrastructure. So we're keeping a very close eye on that. So that concludes my brief discussion of the regulatory experience here in Oklahoma. It's continues to evolve. We keep an eye on it. Our information with respect to whether or not telemedicine continues to be a service that is desired, certainly at $5 a gallon gas in rural Oklahoma, even with time and distance standards that are imposed. It's probably one of the better values for getting primary care, at least here in a rural state like Oklahoma.
Thank you, Deputy Commissioner Rhodes. We're going to take one or two questions before we get to our next speakers for you. Really quickly, Oklahoma is very different from Delaware. So you guys have like a long history with telehealth, like 30 years, going back 30 years. A couple of things I thought were interesting when you were talking on your last slide. And one of the questions I had for you was, how do consumers typically find out that they have telehealth available through their health plan? COVID, I think, like really helped highlight that. But beforehand, was there requirement for information to be sent out from the health plan to like their enrollees, is saying like this is an option now available to you? Was that something that your department would have required, or was that required on the health plans at all?
Not required by the department, and really was a kind of something that the public was really not aware of.
Mm-hmm.
They did not become aware of it until the pandemic hit. And of course, then everybody rushed to establish telehealth and communicate to their insured members that this was a benefit and it should be used. But relatively speaking, and I think that this has been the case in many of the states, kind of a hidden treasure out there that was not tapped until it was really needed and necessary. And when your PCP said, don't come into the office, let's televideo. Only then did it become more noticeable to the public.
Mm-hmm. And then the other thing that was on that slide that I thought was interesting, because I know it's been like a topic of discussion. You said that your department was keeping an eye on those virtual communications or telehealth first policies for primary care.
Yes.
So when you say keep an eye on it, you're just like on alert to like watching it. What would your department initially do? Because I'm not sure if there's like anything in Oklahoma, and I could be wrong, in Oklahoma statute specific to those plans at this point.
Yeah, and the answer to that is we don't know what we're going to do until we see one. But these will come through our rate and form division.
Mm-hmm.
We will begin to look at these programs. Certainly, we have identified some of the vendors out there, Cerebral being one of those. Priority Health has a virtual primary care plan that that is being reviewed currently with the Michigan Department. I'm not too sure, maybe that has already been approved. We're uncertain about where we will take these. And I think that what we do is we go out and we have some visits with not only consumers, with the marketplace, also the carriers, and we talk about the advantages of these or not. So that's why we're in this stage of just watching for and reviewing and seeing what will come through rate and form.
I think a lot of people are too. Thank you so much, Deputy Commissioner Rhodes. We're now going to move on to Deputy Commissioner Kevin Began, who is from Massachusetts. Let me just pull up your slides very quickly here. You could go there. So Kevin P. Began is a Deputy Commissioner within the Massachusetts Division of Insurance. In this role, he directs staff in the review of all health, property, casualty, and life insurance products and advises the Commissioner of Insurance on emerging market issues. Deputy Commissioner Began has been with the Division of Insurance for 28 years. Prior to becoming the Deputy Commissioner, he served as Director of the Bureau of Managed Care and Director of the Health Unit, both within the Division of Insurance. Prior to joining the Division of Insurance, the Deputy Commissioner conducted financial and economic analysis for the Massachusetts State Budget Bureau and Kaiser Foundation Health Plan of the Northeast, and coordinated client pension and 401k plan valuations while employed at Johnson & Higgins and Kawasha Lipton Consulting. He received the Manuel Carvalho Award for Excellence in Public Service individually for implementing managed care reforms in 2001, and as part of a group with the implementation of automobile reforms in 2008. Deputy Commissioner Began holds a master's in public policy and public health from the University of California at Berkeley and a bachelor's of arts degree concentrating in both economics and international relations from Brown University. So I will now turn it over to you.
Thank you very much. Thank you all for being part of today. Good afternoon and good morning. I appreciate being here and I appreciate listening to the previous speakers. We in Massachusetts are different from both Delaware and Oklahoma. For all involved, we are a pretty compact state, but we are pretty populated. So there are not that many rural areas, but there are some. Broadband is not an issue in our state, and we do have cross-border issues, but at the same time, it turns out many people come to Massachusetts for care as opposed to Massachusetts residents going elsewhere. I listened to the two previous presentations, and I would say that we in Massachusetts did not get started as quickly as the other states did to really look at telehealth. And if you don't mind, next slide, May. We did pass laws in 2012 that permitted carriers to cover services when provided via telehealth. So telehealth has been available for a while in Massachusetts. We know that carriers were always willing to talk with providers regarding telehealth, and this law in 2012 only defined what telemedicine was. It identified that an insurance carrier may limit coverage of telemedicine to those healthcare providers in the telemedicine network, and that any services provided should be consistent with coverage for health carriers. But there were a lot of limitations that in law in 2012. It did not apply to HMOs, which represent about 95% of the Massachusetts market, and it did not require coverage of telehealth services. And it did not comment at all regarding reimbursement nor platform use regarding the use of telehealth services. So consequently, despite the passage of the 2012 law, providers and carriers did not develop contracts to include telehealth services, especially regarding reimbursement. It led to a lot of tense negotiations and very little utilization. As a result, there was very limited availability of telehealth through the dedicated telemedicine networks. And Massachusetts, I think, had the availability, but really not the utilization of telehealth. Next slide. As with every state, the world changed with COVID-19. And in Massachusetts, it's almost as if we went from 0 to 70. With the passage of a governor's emergency order, we clarified under bulletins in the state that carriers must reimburse providers for services delivered via telehealth, at least at the rate of reimbursement the carrier would reimburse for the same services when provided via in-person methods. We did need to make clear that providers would need to be willing to certify they comply with all applicable state, federal statutes and regulations governing medication management and prescribing services, and clarified that reimbursement should not include any so-called facility fees for distant or originating sites. We did highlight that there could not be any limitation on what type of telehealth platform would be used. And we made it very clear that this actually applied to all providers. After we implemented our law, I was besieged with calls from many different providers to double check that it applied to physical therapy, early intervention, at-home behavioral health, speech therapy. And we did make sure to make clear to all the carriers and the providers that this did cover telehealth for any and all of those services. From the date that we instituted our bulletin, we made sure to schedule bi-weekly calls with the provider organizations, the Mass Medical Society, the Mass Hospital Association, with probably about 60 to 70 different provider groups on the phone to go over their concerns about any of the implementation for behavioral health so that we could provide additional question and answers to answer questions in the market. We issued bulletins and the Q&As in conjunction with those calls and also with our calls with the carriers to make sure that everything was clear. Next page, next slide. We did require that there be certain telehealth standards so that prior to each patient appointment, the provider must ensure the provider is able to deliver the services to the same standard as in-person care and in compliance with the provider's licensure regulation requirements. The provider must review the patient's medical history and any available medical records with the patient during the service. The provider must inform the patient of how the patient can see a clinician in person in the event of an emergency or otherwise. And the carrier may not impose any prior authorization barriers to obtain medically necessary health services via telehealth that would not apply to receipt of the same services on an in-person basis. Next slide. We spent a great deal of time with carriers to make it clear they needed to develop and identify clear communication about submitting claims for reimbursement. We had carriers submit to the division for us to put on our website and to distribute to providers clear information about their claim reimbursement policy, highlighting what their claim submission documentation guidelines were for exams for office and outpatient visits. We did have them explain that they would continue to evaluate specific CPT code documentation to review the documented reason for the visit medically supports the extent of the exam. And we clarified over and over again that they needed to reimburse at the same levels as for the same services when provided via in-person methods. We found it necessary to have this constant and regular information exchange with the providers and the carriers to make sure it was clear to all there were not going to be any disruptions during the public health emergency. As a result, on the next page, telehealth utilization spiked. And I'm sure this is the same for my colleagues in other states. As of April 2020, at least 75% of all the visits were conducted via telehealth. The key for us is that we did not limit our public health emergency to only a 3 or 4 month period. We continued to require that the carriers and the providers continued with the same standards so that providers knew that they continue to have the right to receive access to use telehealth without any limitations until such time as this was going to be addressed by law or future regulation. As a result, we've seen that behavioral health visits have continued to stay at very high levels being provided by telehealth, so that even today, most recent data for September 2021, 50 to 60% of all behavioral health visits are provided via telehealth. We did have reductions in PCP visits and specialist office visits as providers and patients started to come back to the offices. But even as of September 2021, at 10 to 15% of all office visits were actually conducted via telehealth. Someone had asked whether this had led to any increase in utilization. We have seen a marked increase in behavioral health utilization. We've heard from providers there is much less absenteeism, that continually individuals do show up for their appointments. There were, for other reasons, spikes in utilization for behavioral health during the COVID-19 time period. And we have seen that telehealth has worked to make sure there's been continued access to care. The clear thing, we said, it is working. It makes too much sense to actually try to change the way things were operating. And we made the legislature clearly aware of how things were proceeding. And they did take note and they did pass changes to legislation. Next slide. On January 1st, 2021, and with the law, Chapter 260 of the Acts of 2020, which was passed on January 1st, 2021, it formalized many of the existing features that existed within our COVID-19 public health emergency. And it clarified that telehealth was mandated to be required to be offered through all the carriers in the Commonwealth, and that telehealth required that it was going to cover the use of synchronous or asynchronous audio, video, electronic media, including but not limited to interactive audio, visual, video technology, remote patient monitoring devices, audio-only telephone, and online adaptive interviews. And it was to be used for the purpose of evaluating, diagnosing, consulting, prescribing, treating, or monitoring of a patient's physical health, oral health, mental health, or substance use disorder conditions. Next slide. Under the law, it's required that there is not to be any required mandated telehealth platform. Carriers are not to designate that providers all use a standard platform. Rather, providers are required to follow federal HIPAA guidelines regarding use of telehealth, but they may actually use the platform they're most familiar and comfortable with. We also have identified that carriers may not apply any utilization criteria to determine what is not appropriate to be provided by telehealth. So they can identify that certain things, for example, lancing a boil may not be appropriate, but they need to define this criteria very carefully and make it aware through internet websites that are available to the public and providers what the criteria is so that it's clear to all and can be criticized by all. And likewise, the patient has access not only to telehealth, but the law requires they must have access to in-person providers. Network adequacy is not based on telehealth providers. So as Mike was mentioning, there are some products entering the markets that are talking about virtual first before going to see someone on an in-person basis. That's not allowed under Massachusetts laws. There's a requirement you have the right to access any provider in person. However, many are taking advantage of using telehealth providers first, but it's at their option. The key provision within our law was really payment parity for telehealth visits. Unlike the way that Oklahoma proceeded, our law identified that behavioral health care would permanently be set up so that there would be payment parity for telehealth visits compared to what was provided on an in-person basis. Then the law identified that primary care and chronic care would also be at payment parity, but only through the end of 2022. And they identified that all other care, whether it be for specialty care or anything that doesn't fit under the definition of behavioral health or primary care, would only be at payment parity through mid-September 2021. Next slide. Soon as the law was enacted, we at the Division of Insurance held a series of information sessions, usually with 80 to 90 individuals participating between February and April 2022 to ask questions from different providers, advocates, carriers about how the Division of Insurance should implement all of the provisions of our statute. With this, there were extensive sessions that lasted about 2 hours each, where we dissected all the parts of the law. We knew that we needed to promulgate regulations that would fully implement all the rules of the law so that it was clear for all parties involved. While we were working on regulations, we needed to preserve some element of the status quo so that providers and carriers would know how to operate before the regulations were finally put in place. We clarified by bulletin, both in April and then later in September, that all carriers needed to provide continued access to telehealth. They needed to be very clear, and we would be following up to make sure they had appropriate explanations of documentation necessary for telehealth visits, and that they were constantly explaining how to make sure the codes were properly known by all about how to proceed. Then, regarding that part of our law that identified that there may be changes to payment parity, we identified to all the carriers before they implement any change for 100% reimbursement, they needed to contact us with an implementation plan explaining how they were going to have less than 100% reimbursement for an in-person visit. And they needed to provide very good explanations about the notice they were going to give to providers and patients. One carrier did file an implementation plan. So our Blue Cross and Blue Shield of Massachusetts, they decided they wanted to reimburse at a lower level than 100%. They notified providers by January 1st of changes they were going to be putting into effect on April 1st, 2022, so that telehealth services for non-behavioral health, non-primary care, non-chronic care services were reimbursed on April 1st, beginning at only 80%. The Division of Insurance permitted the plan, but made clear that it was something that could change when DOI promulgated regulations. I would tell you I had more calls from providers between March 15th and April 1st than I've ever had at the time I've been at the Division of Insurance. Next slide. We did draft regulations. Those regulations were released and a regulatory hearing was held on May 11th, 2022. I've provided the web links to both the hearing notice and also to the regulations the Division of Insurance put in place. We had a very robust number of individuals coming to our regulatory hearing. We heard comments, written and oral, from over 40 organizations, and we at the DOI need to clarify and work on defining things that are still very unclear in the minds of many. What is synchronous and asynchronous care? We need to very clearly make this as flexible as it can be, since the modalities of communication continually change. So we need to make sure as we define this that it's not what is available today, but also what's going to be available in the future. We spent a great deal of time working on the word visit. During our pandemic experience, we were unfortunately finding that certain claims came in that became complaints with the Division of Insurance for providers charging for a visit via telehealth when someone contacted them looking for a refill on a prescription medicine, and it was only a 30-second call. It was a surprise to the patient because with a high deductible health plan, they were finding that 30-second call was something that might have cost them $300. We tried to spell out within our definition of visit that the visit should be something that did include a scheduled visit. The consumer would understand if they did operate under a telehealth type arrangement that they may be subject to co-payment and deductibles for that visit, and also to make it clear that it needed to include examination, management, consulting, prescribing, and other features that are part of a doctor visit. Then we have spent a good deal of time trying to define what is primary care, chronic care, and behavioral health care. These are full of debates as different providers have highlighted that they may fit in one category or another. We are trying to sift through, especially for behavioral health care, whether that only would represent something that is provided by a traditional behavioral health provider, or it may be other providers, for example, speech therapy providers that provide services to those who may have behavioral health conditions. We continue to have other questions about process, determining what types of care are appropriate for telehealth, also how to make information available in provider directories about what types of telehealth a provider may actually be willing to offer to a consumer. And then lastly, number of questions about appropriate coding and billing. We have a good deal more to do. During this time frame, most of the carriers in our market are operating the same way they have during the public health emergency. The one company that decided to go a little differently, I think that they are waiting very anxiously to see what the end result is for the division's regulations. And we know when these regulations are put forth, we'll probably need to have more bulletins and question and answer sessions. The only way that we could do this and the only way it works is with many stakeholders being involved in helping us with the process. So I'll stop there. I don't want to take too much time. And thank you again for letting me present today.
Thank you, Deputy Commissioner. Great presentation, and also really highlighting the importance of like the regulatory agency and how in the role that they play in furthering these policies for telehealth. Two really quick questions for you before we get to our next speaker. One is for me. You had mentioned that during the pandemic, you have required carriers to forward to the department their plans for telehealth. And did I misunderstand? Those were made public? You had stored them somewhere on your website for the public to access that? Did I get that correct?
It is correct. We needed to make sure there were clear communications, not only to the division, but to providers. We became a clearinghouse to collect the information that explained their payment policy, the coding, how to actually present the coding in order to get reimbursed. So we found that we could facilitate the communication to make sure there were standardized and clear information we collected from the payers that we could make available to the providers.
And will you continue to do that when Massachusetts moves out of like a public health emergency situation, like in just sort of regular, hopefully knock on wood, everyday life?
We want this to get to a steady state. We think that especially when the public health emergency started, there were not very good communications between the providers and the carriers. We think the communications are much better. Whether we need to be the facilitator of those communications or not, we'll see as time evolves. I think that there is much better communication, but I think right now the regulations need to go into effect so we can really finalize what the final rules are.
All right, thank you so much. We're going to move on to our next speaker. We've heard of the important role that the regulatory agencies play in implementing a telehealth law. Now we're going to actually hear about from someone who it impacts directly, these commercial payer telehealth policy laws. So I'm happy to introduce Chelsea Matter, who is the Executive Director of Government Programs, Health Integration at Blue Cross Blue Shield of North Dakota. She joined Blue Cross Blue Shield of North Dakota in December of 2011 after spending time at a local public health unit and working as a respiratory therapist at a local hospital. During her tenure there, she has guided alternative payment model formulations, expanded the provider network, and advised on numerous state-focused policy efforts. Upon award of the Medicaid expansion business in 2021, Chelsea transitioned into her current role as Executive Director of Government Programs. In this role, she oversees Blue Cross Blue Shield North Dakota's relationship with the state of North Dakota and actively participates in policy work with the Government Affairs team. An active community member, Chelsea serves as the board chair for Fargo Cass Public Health Boards of Fargo Cass Public Health Board of Health and previously served as president of the North Dakota Public Health Association. Sorry for that. Chelsea also chaired the successful statewide effort to make North Dakota smoke-free in 2012. Chelsea holds a bachelor's degree in respiratory care from North Dakota State University and a master's in public health degree from the University of Nebraska Medical Center. And my apologies for mangling that board's name there. So I will now turn it over to Chelsea as I bring up her slides.
All right, excellent. Hello, I'm happy to be with you all today and share that payer perspective with regard to implementing this various telehealth policies. And I want to thank my fellow panelists who have really set up this discussion well. And it's nice to hear that we have similar challenges in this space. So on the next slide, just first a little bit of history. As you all probably are aware, North Dakota is a pretty rural state. We are one of the states that has more cows than people. So early on, we recognized that we need to connect people virtually because folks don't necessarily have access to the healthcare providers they need when they need them. And so we're also very fortunate as a state to have a very good infrastructure for telehealth because we're ranked as one of the top 10 states for the best internet access. So really good infrastructure to support the telehealth efforts that we've had. So we actually issued our first telehealth policy in 1994 and went relatively unchanged. So no major overhauls really to the telehealth policy until we started to see more mobile-based telehealth solutions. So Teladoc, Amwell, their emergence into the market, probably 2013, 2014, and then started to see a little bit more activity around coverage parity, which I know others have talked about, and certainly payment parity was brought up. And then more recently, more changes have come about as a result of the pandemic. So we'll move on to the next slide and talk through what utilization has looked like for us. And so this graph on the right-hand side probably looks very similar to any other payer that you can encounter. Pre-pandemic, we had anywhere from 2,000 to 3,000 visits per year. And the majority of those visits were really dominated by two different service types. So behavioral health, but also infertility. We don't have very many fertility specialists in the state outside of the Fargo area. And so that was a really heavy service line to be utilized for telehealth. And then of course, pandemic came and you can see the very big spike there in March of 2020. And we went from that 2,000 to 3,000 visits per year to 4,000 visits per week on average, with a peak of about 7,000 visits. So a very dramatic uptake. And as others have mentioned, with that uptake, we had a huge increase in the amount of questions that we were getting. Providers that had never used telehealth before were really scrambling to figure out how to implement a telehealth solution. And we were really trying to be responsive to those questions to figure out a way to keep people out of their facilities and safely at home. And so what we thought was a very solid telehealth policy needed some refinements and really a lot of provider education around what is and is not allowed in this realm. Behavioral health obviously continued to be a very predominant reason for people to use telehealth. You can see on the slide, anxiety and depression are by far the most prominent diagnoses that we see in our telehealth claims. And now this year we've seen a little bit of the utilization level off. We have an average of about 1,500 visits per week. But again, going from 2,000 per year to 1,500 per week it really signals that more individuals are going to continue using it. And although we've seen some national member surveys, and it's really starting to suggest that people are probably going to land on some type of hybrid model, right? So seeing their in-person providers and then doing telehealth in situations where it may be more convenient. So it's here to stay. I think we all know that. So on the next slide, during the beginning of the pandemic, the insurance department was really helpful in bringing together all the payers to have some collective discussions around telehealth standards. So as the other speakers were talking, I was nodding my head because a lot of the same things happened here in North Dakota, because we were starting to have national announcements around payers and the Blue Cross Blue Shield Association, as well as other national carriers were saying, we're going to waive cost share for telehealth and make changes to increase access and remove barriers. And so the goal of really bringing all the payers together was to understand what we're already doing and if barriers existed and what we could do to keep people out of these facilities whenever possible. So we had that series of meetings, a lot of discussions, a lot of questions around, definitions. All of those things were talked about amongst the payers, and we have landed on kind of a core set of requirements that made its way into the Insurance Commissioner's Bulletin and into the Governor's Executive Order. By and large, most of the things that were implemented or were talked about, we already had solidified in telehealth policy. Again, we've had a lot of investments for a very long time in telehealth. And so we did have a few changes. So obviously talked a little bit about kind of the stance on the HIPAA compliant software platforms that the federal government kind of said, okay, let's get people care. And so we saw a lot of very small behavioral health practices that needed to quickly pivot, find some software and start delivering services. And so we ended up adding a lot of disclaimers to our medical policy, basically deferring to the federal government on this in terms of HIPAA compliant software and making allowances where the federal government does allow that. So that was very helpful to our small practices and maybe was a barrier previously. One of the changes that was talked about in the Massachusetts discussion, and I believe maybe others, is that we added audio only codes. And this is, as a payer, one of the concerning areas where we could see overutilization. So we were concerned of exactly what Massachusetts was talking about. Somebody called, a doctor called and gave a patient their test results and they received a bill for that. So we did add audio only codes, but we were very specific in the situations in which we would allow. We don't want folks who, the regular day-to-day communication that may happen between a provider practice and a patient, not all of those things can be billable. So we're trying to really create some guardrails around when that's appropriate to bill for and when it's not. And then we also actually made a change in 2018 to allow for group therapy, but I put it on the slide because nobody really did that until the pandemic. And we had a whole host of questions around can they deliver group therapy? And it was a change that our state Medicaid department made for state Medicaid as a result of the pandemic. So those are some of the more major components, and I'll get into a few other pieces here as well. So on the next slide, 2021 legislative session rolled around. So we've already been going through, nope, you can stay on this slide, rolled around, and we started to see a lot more activity, obviously around telehealth and a push in particular for payment parity. One more slide forward. And we also saw a lot of different provider types come forward and wanting to push for inclusion. So we saw the dentists come forward, we saw the chiropractors come forward and push for inclusion in telehealth to make sure that they had a spot. And honestly, with the surge in telehealth utilization, we weren't really surprised by the amount of activity that started to ramp up around this topic. So many more provider types were engaging, and folks really didn't want to be left behind. And we're trying to find their niche in terms of telehealth and what they could do. We did come out of session with some updates to the state telehealth lab, but we also had an interim study to look at a variety of items, primarily focused on reimbursement, and does it make sense to reimburse telehealth visits at the same rate as in-person visits. And so we at Blue Cross Blue Shield North Dakota felt like, behavioral health is one of the primary modes for which people use telehealth, and it, makes sense as a clinical person. I can see that behavioral health could really lend itself well to telehealth, and so we made a commitment at that point to look at those services for potential expansion of payment. So on the next slide, one of the pieces that we felt was missing was understanding how our members felt about telehealth. And so providers were very much pushing for payment parity, and we wanted to ask some questions of our members. So we did a survey, and these are two of the questions that I found really interesting. So the first question was, why did you choose a virtual visit over an in-person visit? And, avoiding travel was the top pick. Understandable. North Dakota has some pretty harsh winters, so I get that. And then right behind that is, it was the only option available to me. And so that tells us that, telehealth is certainly a great option, but some folks were doing it out of the sheer fact that providers weren't allowing them to come into the office. And so their answer might have been different, or they may have chose a different mode had they been allowed to come in person. So I think that seems to be true from the decline that we've seen since the height of the pandemic and the use of telehealth, that folks are taking, again, that little bit more hybrid approach and using it telehealth if they need to, but otherwise maintaining that in-person relationship as well. The second question was, if we charge the same amount for a virtual visit as an in-person visit, what would you do? So along the same lines of what's been discussed, we have high deductible health plans, and folks are exposed to the cost associated with reimbursement for these visits. And so do they value the virtual visit? Do they view that as equal to the in-person visit? And you can see the majority of folks would not be likely to continue with a virtual visit. So meaning they don't view those in all cases as equal. So I think that's a really important point to make here, is we need to be mindful of the consumer impact of these things and how they view in-person versus virtual care, and what spaces it makes sense to have that payment parity in. So on the next slide, as we look forward, as mentioned, we've incorporated a couple of different additions into our telehealth policy. So that audio only, again, very specific conditions around the use of that mode, teledentistry, chiropractic care, e-visits. There's some nuances with the e-visits. Typically that's EMR based or electronic medical record based, but we do have a face-to-face component with that. And then we did expand payment for behavioral health. We removed the site of service differential for our most highly utilized areas of behavioral health, because again, behavioral health is a really great example of an effective use of telehealth, and the experience should be pretty spot on to what you would see in an in-person visit. So we're going to continue to refine these telehealth policies moving forward, and we always encourage providers to bring forward their questions related to our policies. We have a behavioral health advisory committee that's really helped in shaping some of the work that we've done in this space. And then we also actively participate in a statewide telehealth work group with many other providers and state leaders to think through like what we want to do moving forward. And as a result of the pandemic, we feel like we have pretty solid educational material now for telehealth. We thought we did prior to the pandemic, but again, as new providers that had never done telehealth before started doing it, there was a whole host of new questions. So we have very detailed instructions, which I think is really important, especially in a time of crisis, and they're trying to quickly pivot and figure out what's allowable. We really boosted up our specific education material. And then continuing to monitor for inappropriate use of telehealth. We did find some pretty unusual things during COVID, and so not a lot, but enough that it's just something to keep tabs on. And then I can't stress enough the importance of multi-stakeholder engagement and collaboration. And that engagement is really, really key, not only on the front end. So we did a lot of work on the front end to collaborate with state leaders, both, kind of during the legislative process and during implementation, but also internally engaging several areas within our company. So our benefits team, medical policy team, provider education, marketing, making sure we always have a pulse in what the consumer is wanting as well. Again, state collaboration with payers was super helpful throughout this process. Keeping in mind that not all services are equally aligned. Some services are just better suited for telehealth, and we just need to be mindful of the impact that these consumers are having to pay, especially those with those high deductible plans. And then finally, as good as our intentions are with expanding telehealth on all sides, there always seems to be situations that arise that call into question whether or not this is the best mode of healthcare delivery for the patient. And so making sure that we're watching for those inappropriate patterns of utilization. And overall, telehealth is a really fantastic tool and a super important part of our healthcare ecosystem moving forward. It has been for a long time in North Dakota and continue to expand it as it makes sense. And I will stop there. I know we're running low on time.
Actually, you were just perfect there, Chelsea. So thank you so much for that great presentation. We have actually an interesting question, and I'm not quite sure if you can answer here from a Heather Sojourner, Sojourner. Sorry if I'm pronouncing anybody's name wrong. For behavioral health, are family physicians, primary care providers reimbursed at the same level as psychiatrists, licensed social workers, and psychologists? Are health plans requiring code modifiers to delineate professional training or reimbursement is related to diagnostics codes only?
So that seems to be broader than maybe a telehealth question. So there are differences typically in the provider types between behavioral health versus primary care. We do require modifiers on any telehealth claims so that we know the mode of delivery. And so there's some standard, 2 different standard modifiers that we require plans to apply. For those behavioral health services where we did expand, those are specific to the codes. And so whatever they would have received in person is what they're going to receive via telehealth. So we want the modifier on there because we want to take into account what's happening via telehealth, but the payment would be the same again for those specific behavioral health. And we did look at those that were most highly utilized as a starting point.
Okay. We have a question from a Sarah Hines. Would Blue Cross Blue Shield North Dakota like to see any specific telehealth policies implemented at the state or federal level? Are there any areas where your telehealth flexibilities are more generous than what was required by state or federal law?
A good question. I like that question. I don't know that I have a great answer off the top of my head for that one, though. I think we've had really great communication within the state, a lot of great stakeholder engagement. And so where we've had any barriers, we've been able to talk through them. Like I mentioned, we've been doing this for a long time, and we have great broadband access. And so we don't maybe have some of the limitations that other states have had. So I think we are certainly collaborating on anything that we need to, but I can't think of anything specific that we haven't already pursued in this realm.
Okay. If I could have all the panelists back, we have time for one more question, and there's an interesting one in here. Okay, I think we've got everybody. So this is from someone who wanted to remain anonymous, but it's for all of you. The growth of high deductible plans has resulted in many patients seeking direct primary care by paying a subscription, which can be less expensive than their deductibles. How does direct primary care intersect with telemedicine regulations in your state?
Well, in Massachusetts, we've seen the increase of direct medical care plans, and we don't see them, if they've been constituted according to our rules, as insurance. So we wouldn't specifically require them to follow the same telehealth rules that we follow, but we would encourage them to look at the telehealth rules and look at ways that they could do things similarly that we're requiring for insurance companies. Not sure if my fellow panelists do it differently in other states.
Kevin, similar circumstances in Oklahoma.
I'm not aware of that being handled any differently in Delaware either.
Yeah, we haven't seen a whole lot of direct primary care activity in North Dakota yet. We're typically trendsetters, but we haven't seen that yet.
All right, then I know we have a lot more questions for our panelists, but we are at time. So I wanted to thank you all again. Great presentation today. Has been incredibly informative. Thank you for taking time out of your incredibly busy schedules to share your knowledge with us today. So just very quickly here, again, thank you to Representative David Bentz, to Deputy Commissioner Kevin Began, Deputy Commissioner Mike Rhodes, and of course, Chelsea Matter from Blue Cross Blue Shield of North Dakota. You guys all were great. Thank you so much. Just to let our attendees know that you can subscribe to CCHP's newsletter for more information around telehealth policy or for any upcoming webinars we may be holding. Past recordings of webinars that we have held is available on the CCHP website along with the PowerPoint presentations. You will be receiving an evaluation form when you sign out from the webinar today, so please fill that out. That would really help us out with our future webinar plannings and any other type of work that we do here at CCHP. For next week, our last webinar of the series will be on substance use disorder, and these are the speakers that we have. We have representatives from SAMHSA, from the Arkansas Department of Human Services, and also from the Philadelphia Department of Public Health, speaking on substance use disorder and telehealth. Once again, I know there were a lot of questions on why it was specific to certain states, why our speakers focused in on that. Again, we were trying to give a broad range of what has happened over telehealth policies and telehealth private payer laws and how different states responded to them. So other states can learn from the experiences of these states, like what they went through in passing a law, implementing a law, and also the impact on the health plans that, were subject to these laws. Once again, we ask you to fill out the evaluation form. Recordings will be made available a couple of days after this webinar. Thank you again to our panelists, and thank you to all of our attendees. Have a great day and a great weekend.
Thanks for having us. Take care.